Hello everyone. Hope you all are happy and healthy and utilizing your vacations in a wise manner. This is a part 4 of the Disorders of Adrenal Gland series. In this video, I'm covering aldosteronism and conn syndrome. A long question can come on aldosteronism and a short note can come on conn syndrome. So let's start with the PPT. So aldosteronism and conn syndrome. It is a part related to endocrine hypertension. The patients in aldosteronism and conn syndrome will present as a hypertensive patient which is not controlled by conventional allopathic medicines or poorly controlled by them, and a presentation at a young age. So hypertension, as you all know, is of two types: essential hypertension and secondary hypertension. While the majority of patients with hypertension have either no discernible cause, that is known as essential hypertension, or underlying renal parenchymal or renovascular disease, a small percentage have an underlying endocrine cause. So, in which there is no causes, primary or essential hypertension, and other causes are classified under secondary hypertension. So, endocrine hypertension is secondary cause of hypertension. The precise proportion is variable depending on the diagnostic criteria applied, but most cases of endocrine hypertension are related to mineralocorticoid excess, that is aldosteronism, catecholamine excess, that is pheochromocytoma, Cushing syndrome, hyperparathyroidism, acromegaly, and thyroid dysfunction. So today's topic is mineralocorticoid excess or hyperaldosteronism, which is a secondary cause of hypertension. This is called by various names or synonyms, that is mineralocorticoid excess, aldosteronism, or hyperaldosteronism. And indications I have discussed earlier. Indications to test for mineralocorticoid excess in an hypertensive patient include hypokalemia, poor control of blood pressure with conventional therapy, or presentation at a young age. So if you come across a patient of hypertension who present at an early age, that means around 35 to 40 years, young male or female, when presents with high BP, and you advise them certain tests like the electrolytes test. So you come across hypokalemia, that is decreased potassium in the blood, and also a history of poor control of BP with conventional allopathic medicines. So you will suspect it might be a case of mineralocorticoid excess, and you will go for investigations for mineralocorticoid or aldosterone assay, right? So this will be the presentation of aldosteronism. Young patient presenting with high BP, poorly controlled with allopathic medicines, and having hypokalemia, that is presenting with fatigue, malaise, cramps, dehydration. So you will go for investigations for mineralocorticoid, that is aldosterone. For a quick recap, aldosterone is a hormone, adrenal hormone, which helps to regulate the blood volume, blood pressure, and levels of sodium, potassium, and hydrogen ions in the blood. So this is the normal physiological process. Any cause which will decrease the blood volume or the blood pressure will cause increased renin and increased amounts of aldosterone by the zona glomerulosa of adrenal cortex, and this increased aldosterone will maintain the blood volume by increased sodium and water reabsorption and increased excretion of potassium and hydrogen ions into the urine. And this increased sodium and water will lead to normalizing of the blood pressure, which was low earlier. Now it will become normal. This is the normal physiology. But any cause which will increase the aldosterone inappropriately without these external causes will lead to a patient presenting with hypertension, right? Aldosteronism. The definition is condition of excessive or inappropriate secretion of aldosterone from zona glomerulosa of adrenal gland, which leads to hypertension due to sodium retention and suppression of plasma renin and hypokalemia, right? There are three types of aldosteronism. First is primary hyperaldosteronism, also known as conn syndrome, in which there is excessive production of aldosterone within the adrenals. Primary means the cause is inside the gland itself. Secondary hyperaldosteronism, secondary means the cause is outside the adrenal gland. Excessive production of aldosterone, extra adrenals. And third is non-aldosterone dependent activation of mineralocorticoid receptor pathway. Normally, the mineralocorticoid receptors are activated via aldosterone. But in this case, the receptors are activated besides aldosterone by some other pathways. First, we will discuss secondary hyperaldosteronism, in which the cause is extra adrenals or outside the adrenal gland. In this, the renin is high and aldosterone is also high. So, the first stimulus is inadequate renal perfusion, as we have seen in the earlier picture slide of normal physiology of aldosterone. The inadequate renal perfusion will lead to increased secretion of renin, and increased secretion of renin will lead to increased secretion of aldosterone. So, how this inadequate renal perfusion or inadequate blood supply to kidney by diuretic therapy, due to cardiac failure, due to liver failure, due to nephrotic syndrome, or due to renal artery stenosis. All these causes can cause reduced blood supply to kidneys, which will lead to increased renin and increased aldosterone. Or other causes, renin secreting renal tumor or reninoma, which is rare cause comparatively. This is pictorial representation of the causes of secondary hyperaldosteronism. The renal artery stenosis, cardiac failure, liver failure, nephrotic syndrome, and diuretic therapy. All these will lead to decreased renal perfusion or reduced blood supply to the kidney, which will sensed by the juxtaglomerular apparatus of kidneys, which will secrete increased amounts of renin, which will stimulate the zona glomerulosa of adrenal cortex via angiotensin 2 and cause increased secretion of aldosterone. And another cause is renin secreting renal tumor, which will lead to increased secretion of renin, which will lead to increased aldosterone. This is another type in which there is non-aldosterone dependent activation of mineralocorticoid receptor pathways. In this, renin is low and aldosterone is also low. So both these hormones are low, but still these receptors get activated by ectopic ACTH syndrome. Ectopic ACTH syndrome or through cortisol, hypercortisolism. Cortisol, due to its similarity in structure to aldosterone, can activate the mineralocorticoid receptors. Licorice misuse. Licorice will inhibit the 11 beta HSD2 enzyme. This enzyme is required to inactivate the excess of the aldosterone. If this will get inhibited, so the mineralocorticoid receptors are activated more. Liddle syndrome, in which there is epithelial cell sodium channel activation, which will lead to more mineralocorticoid receptor activation. 11-deoxycorticosterone secreting adrenal tumor. This is a precursor hormone which will activate the mineralocorticoid receptors. Rare form of congenital adrenal hyperplasia and 11-beta HSD2 deficiency. In this also, congenital adrenal hyperplasia, there is activation of mineralocorticoid receptor pathways. The distal nephron is activated even though aldosterone levels are low. The receptors are activated by cortisol, as in ectopic ACTH syndrome, or 11-beta HSD2 deficiency, or 11-deoxycorticosterone tumors, or post-receptor mechanisms like the epithelial sodium channels and Liddle syndrome. This we have discussed in the previous slide. Just a recap of it. Now we move on to primary hyperaldosteronism with renin low and aldosterone high. The most common cause is adrenocortical adenoma, also known as conn syndrome, in which there is a tumor in the adrenal cortical layer secreting aldosterone. Most cases are unilateral but maybe bilateral cases, commonly seen in women, and age group is 30 to 50 years. That means early presentation in women, unilateral mostly, right? Poorly controlled with allopathic medicines. In 20% of cases, there is bilateral adrenal hyperplasia, which is usually of idiopathic origin. Adrenal carcinoma is a rare cause. Another cause of primary hyperaldosteronism is glucocorticoid suppressible hyperaldosteronism, which is a genetic cause. Glucocorticoid suppressible hyperaldosteronism is a rare autosomal dominant disorder caused by translocation of two homologous genes, such that the ACTH regulated promoter of one gene, 11-beta hydroxylase, is linked with the coding exons of another aldosterone synthase. Right? So these both get linked, and the result is inappropriate secretion of aldosterone from the adrenals in response to normal levels of ACTH despite suppression of renin and angiotensin 2 levels. So such mutation happens in which the normal levels of ACTH will stimulate the adrenals to secrete inappropriately excessive aldosterone despite the suppressed amounts of renin and angiotensin 2 levels. The aldosterone is high. So what happens in primary aldosterone excess or conn syndrome? Generally a tumor, mostly unilateral. Aldosterone increases due to increased activity of cells producing the hormone, leads to hypernatremia, that is sodium retention, hypokalemia, that is decreased amounts of potassium in the blood, hypervolemia, that means due to water reabsorption, increased water reabsorption, and alkalosis due to increased amounts of removal of hydrogen ions from the body. The result is hypertension that is poorly controlled. Pathophysiology is hypersecretion of aldosterone will lead to sodium retention and potassium and hydrogen loss. Sodium retention will expand the fluid volume, which will cause hypertension. Most patients will have moderate hypertension. Malignant hypertension and papilledema rarely seen. Hypokalemia will result in muscular weakness, cardiac irritability, arrhythmias, and carbohydrate intolerance. So you will have a patient of hypertension who has an increased risk of heart attacks and arrhythmias. And loss of hydrogen leads to metabolic alkalosis and sometimes may leads to tetany due to low ionized calcium levels. And due to impairment of concentrating ability, polyuria is seen in many patients. So polyuria will cover up the edema. So edema is characteristically absent in Conn syndrome. So the mnemonic for Conn syndrome for easily remembering is, the phonetics of C is K, potassium. So potassium is low by 1 plus, and 2N signifies, that means sodium. Sodium is high. Sodium is more in comparison to potassium. That means hypernatremia and hypokalemia, and edema is absent. So you make a note of it somewhere. Potassium is low, sodium high, and edema absent. Clinical features of Conn syndrome: high blood pressure, which is usually hard to control, and patients are often on 4 or more blood pressure medications and usually manifested clinically as headache, blurred vision, and dizziness. The low potassium levels can cause symptoms like fatigue, numbness, increased urination, increased thirst, muscle cramps, and muscle weakness. There is increased risk for heart attacks, heart failure, strokes, kidney failure, and early death. So it is a fatal condition if not controlled at the right time. But the removal of tumor makes it a treatable condition. Investigations. First, you have to do the general physical examination in which the vitals have to be taken, the blood pressure is raised. All patients of hypertension with hypokalemia should be screened for this syndrome. Biochemical investigations include test for potassium and sodium. Normal levels of potassium is below 5, 3.6 to 5 millimoles per liter, and normal sodium is 135 to 145 millimoles per liter. So less than 3.6 millimoles is hypokalemia, and metabolic alkalosis, that means pH is above 7, are present with elevated bicarbonates. Plasma sodium is usually towards the upper end of the normal range, that is more than 145 in primary mineralocorticoid excess, that is in Conn syndrome, but is characteristically low in secondary hyperaldosteronism, because low plasma volume will stimulate ADH release and high angiotensin 2 levels will stimulate thirst. So it will dilute the sodium. And also there is suppression of plasma renin activity in Conn syndrome, that is in primary. There is suppression of plasma renin activity but high renin in secondary. Plasma and urinary aldosterone levels are high. These are the investigations for Conn syndrome. Urine test, overnight concentration test, impaired ability to concentrate the urine. Urine is alkaline. Urinary potassium is more than 30 milliequals per day, is inappropriately high as compared to serum potassium, that is below 3 milliequals per liter. So the urine is alkaline because of the impaired inability of kidneys to concentrate urine. And urinary potassium is high because it is the potassium ions are excreted in the urine, but the serum potassium is low. That is, potassium in blood is below 3.6. The key measurements are plasma renin activity and aldosterone. So the key measurements of renin and aldosterone has to be done, and almost all antihypertensive drugs interfere with these hormones, that is renin and aldosterone. Examples: beta blockers inhibit, by thiazide diuretics stimulate renin secretion. Right, so these should be stopped for at least 6 weeks beforehand. If this is not possible, then antihypertensive which have minimal effects on renin angiotensin system, such as calcium antagonist and alpha blockers, should be employed. So these should be employed before doing the measurements of renin and aldosterone. If renin is low and aldosterone levels are high, then Cohn's adenoma should be differentiated from bilateral adrenal hypoplasia by test of aldosterone response to angiotensin 2. So if the renin is low and aldosterone is high, then two conditions might be suspected. That is, one is Cohn syndrome and another is bilateral adrenal hyperplasia. Now these can be differentiated by giving synthetic angiotensin 2 or furosemide, by which there is no response of or increased amounts of aldosterone by Cohn syndrome, but the in bilateral adrenal hyperplasia there will be decreased amounts. So in Cohn's adenoma, aldosterone does not rise on standing or with furosemide administration. In the rare circumstance when renin and aldosterone are both low, as in non-aldosterone dependent mineralocorticoid receptor activation pathways, further tests include measurements of urinary cortisol and its metabolites and 11-deoxycorticosterone. There might be a tumor which is secreting deoxycorticosterone, which is a precursor hormone of aldosterone. So the hypokalemia will lead to changes in the ECG of cardiac arrhythmia and sometimes left ventricular hypertrophy. Right? So there are fibrillary waves can be seen. Other causes of hypokalemia like diuretic therapy, gastrointestinal losses, starvation, renal disease and metabolic acidosis should be ruled out. There is T-wave flattening and inversion. The T-wave, which is usually up, becomes flattened and inverted. There is ST depression. Prominent U waves, best seen in precordial leads. And apparently long QT interval due to fusion of T and U waves. So this long QU interval in hypokalemia. Localization of adenoma. CT scan are effective in identifying adenomas, especially if they are more than 1 centimeter in diameter. And MRI offers no advantage over CT scans. In both of them, it can be diagnosed. Adrenal radioisotope scanning with idocholesterol or NP59 helps to differentiate adenoma from bilateral adrenal hyperplasia. So, radioisotope scanning can be done with the help of these agents to differentiate adenoma from bilateral adrenal hyperplasia. Catheterization of adrenal veins for aldosterone levels are accurate but technically difficult method of diagnosing adrenal pathology in primary hyperaldosteronism. So catheterization of adrenal, a catheter can be introduced inside the veins to check for the aldosterone levels, but these are very difficult method and require expert technicians. This is a CT scan showing a left adrenal adenoma by the white arrow. This is the MRI showing adrenal adenoma above the right kidney, right adrenal adenoma. This is 131 ido-not cholesterol scan showing uptake in left adrenal adenoma by the arrow. This is a tumor, canary yellow in color because of the intracellular lipid accumulation. Management is by unilateral adrenalectomy is the treatment of choice in patients with adrenal adenoma, which is unilateral. Okay? In patients with bilateral adrenal hyperplasia, medical treatment is recommended. The adrenal antagonist spironolactone is given in a single dose, and other potassium sparing diuretics like amiloride may be used, but they may have side effects, so they have to be beware. The homeopathic therapeutics of Cohn syndrome are belladonna, calcarea, glonoine, natramure, ignatia, gelsemium, causticum, calcarea groups, magnesias, phosphorus, cactus, crataegus, rolfia. So hope you have understood the topic well. Please go through it again until you get to the core of it. Thank you.